Welcome everyone. Thank you for joining us today. Just so you know, today's session will be recorded, and since this is a webinar, you are all automatically muted. Please feel free to introduce yourself in the chat with your name, job title, and where you work. Also share where you're calling us from. And we will give folks another minute to join before we get started. But I will ask to go to the next slide so you can see our speakers for today. Thank you. So I'll give another few seconds for folks to get on. All right, so people are coming in. Thank you. Thank you for introducing yourselves in the chat. Feel free to continue to do so. And I will introduce myself soon too, but just briefly, I'm John Wen Yap. I'm the Associate Director of Health Equity here at the Association of Asian Pacific Community Health Organizations, which is AAPCHO. I'll share a little bit more about us. Again, we have two featured speakers today for our webinar today, Dr. Adi Rosario and Dr. Cha Wang, and I will provide a deeper, longer introduction to them. I'm just providing some time for people to get in right now. And thank you all for being here. I hope you're all doing well and staying as safe as you can. I see some former coworkers in the chat, so hello. Let's go and we're get people in. So since this is a webinar, you will not have the option to turn on your camera or unmute. However, if you would like to participate, please use the functions at the bottom of the Zoom screen. You'll see the icons here. For informal conversational contributions, please use the chat box. And remember to click on the blue button to make sure it says everyone if you want to share it with the whole audience. And for questions for our panelists or regarding content, please use the Q&A box. Again, there's the icon with the Q&A. And when possible, please direct your questions to the specific speakers to streamline our Q&A process. If you'd like closed captions, please click the live transcript button on the bottom of your screen and select show subtitle. We put the call-in information in the chat box, or we will. And if you have any tech support needs, please send a chat to panelists or Christine Alarcon at AAPCHO. And one final note that we'll be sharing the slides, recording, and speaker information after the webinar. All right, next slide. And this is our phone audio. You should have received it also in your Zoom registration, but we could share that in the chat soon. All right, thank you. If you have not already done so, please introduce yourself in the chat with your name, job title, and where you work. Please remember to select all panelists and attendees before sharing again, or put everyone. My name is John Wen Yap, and I'm Associate Director of Health Equity for the Association of Asian Pacific Community Health Organizations, or AAPCHO. AAPCHO was formed to create a national voice to advocate for the unique and diverse health needs of Asian American, Native Hawaiian, and Pacific Islander communities and the community health providers that serve their needs. We are joined today by our partner for this event, the U.S. Department of Health and Human Services, or also known as HHS, and their We Can Do This campaign. This HHS COVID-19 public education campaign is a national initiative to increase public confidence and an uptake of COVID-19 vaccines while reinforcing basic prevention measures such as mask wearing and social distancing. And I see more people are introducing themselves, so this is great. The Asian American, Native Hawaiian, and Pacific Islander community continues to be disproportionately affected by COVID-19. At AAPCHO, we have learned and continue to see how the pandemic has served as a catalyst for Asian American, Native Hawaiian, and Pacific Islander communities and organizations to collaborate on an unprecedented level nationally increasing critical partnerships between trusted community-based organizations and health system partners to ensure equitable distribution of vaccines. Next slide. And again, we are AAPCHO, and I had shared this earlier. Go next slide, please. Our mission at AAPCHO is dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of Asian Americans, Native Hawaiians, and Pacific Islanders within the United States, US territories, and the freely associated states. We are a member organization, and we currently have 33 member community health organizations and other key partners and networks that serve Asian American and Native Hawaiian and Pacific Islander communities. Next slide. So today's learning objectives are to 1, understand the effectiveness of COVID-19 vaccine boosters. 2, recognize how Asian American and Native Hawaiian / Pacific Islander communities can access COVID-19 vaccine boosters. And 3, to increase your ability to encourage patients, community members, and families to reach full vaccination protection. All right. So for our agenda for today, we're going to do you're doing our introductions. And again, thank you for introducing yourself in the chat and continue to do so. We are going to have 2 featured speakers as a panel, and then we'll do some Q&A, and then we'll share some resources and do an evaluation at the end. Christine, can we launch the poll? So we're curious, who do you plan to share this information with? Are you planning to share with family members, with friends, parents, patients, other? And you could choose as many as is relevant to you. And you can also, if you click other, please feel free to share it in the chat. And we'll give you a minute or 2 to enter the poll.
We have about 30 more seconds for the poll.
Thank you, Christine. All right, thank you. Thank you all for participating. It looks like 70% want to share it with friends. We'll be sharing it with friends, and 62% are sharing it with family members. The 38% of you that will be sharing it with parents, and 49% to patients, and 40% to others. And I see 1 comment sharing it with community health centers. Thank you, Jennifer. And feel free to add any other audience or any other people that you will be sharing the information that you learned today or you gathered today. Thank you for that participation, and we'll keep looking. Other staff, thank you. All right, so now I'm going to have the pleasure to introduce our featured speakers. Next slide. All right. All right. Dr. Adelaida Rosario, Dr. Addie Rosario's PhD studies the connections between behaviors and social and cultural determinants and how these factors affect health disparities for different minority communities. She has worked with Hispanic and Pacific Islander populations to study how these factors relate to early childhood development, mental health, risk behaviors, HIV/AIDS prevention, and substance abuse. Dr. Rosario is involved in numerous efforts and collaborations to increase diversity in the biomedical and federal workforce. Dr. Rosario earned her PhD in social welfare from Florida International University, an MA in Pacific Micronesian Studies from the University of Guam, and a BA in psychology with a minor in religious studies from FIU. And Dr. Rosario is a lieutenant at the Surgeon General's office at the U.S. Department of Health and Human Services. Next slide. And our other speaker is Dr. Cha Wong, MD, MS, is infectious disease consultant for the COVID-19 and other infectious diseases Health Equity Response Network, CHERN at AAPCHO, and the Pacific Islander Center of Primary Care Excellence. Dr. Wong also works as an infectious disease specialist at International Community Health Services, which is FQHC in Seattle, and Virginia Mason Medical Center, and clinical associate professor of medicine at the University of Washington. Dr. Wong's outpatient clinical interests include hepatitis B and C, HIV/AIDS care, and travel health. All right. And now we're going to have Dr. Rosario share about COVID-19 vaccines and Asian American, Native Hawaiian, and Pacific Islander communities. So we'll feature Dr. Rosario and we'll stop sharing the slides for now.
Thank you, John, and thank you to the Association of Asian Pacific Community Health Organizations, AAPCHO, for inviting me to be here today. I'm so honored to be with you all to talk about how we can keep our communities and our families safer from COVID-19. So as introduced, my name is Dr. Addie Rosario, and I'm with the U.S. Public Health Service in the Office of the Surgeon General. I'm here on behalf of the U.S. Department of Health and Human Services We Can Do This public education campaign. We Can Do This is a national initiative to increase public confidence in and uptake of the COVID-19 vaccines while reinforcing basic prevention measures. But I'm also here because I'm a person of Chamorro descent, born on Guam in the village of Dededo, a U.S. territory, and I'm a parent of an 11-year-old daughter going on 18 as well. Like many parents, my number one priority is my child's health and safety, and of course that of my family and community. My work is also focused on health inequities, and there is still so much more to be done in this space. With more of us planning to travel this winter, gather with family and friends for the holidays, and participate in community festivals, one big way that we can keep everyone safer is to get vaccinated as soon as possible. Widespread vaccination is critical to ending the pandemic. We've all seen that we've had COVID vaccines for about a year now, and hundreds of millions of people in the US have safely gotten vaccinated. So what do we know so far? We know the COVID vaccines work. We have real world evidence that shows that if you're vaccinated, your risk of infection, hospitalization, and death from COVID are all much lower than if you're unvaccinated. In fact, as of December 20th, 65% of people aged 5 and up have been fully vaccinated. That's nearly 2 out of every 3 eligible persons that now has a sense of relief and peace of mind, knowing that they are protected from serious illness, hospitalization, and death. And we haven't yet seen any long-term side effects. The risks from COVID far outweigh any risks from the benefits from the COVID vaccine far outweigh any risks from the side effects. And unvaccinated people are 10 times more likely to be hospitalized from COVID-19 than people who have been vaccinated. So in regards to where you can get a COVID vaccine, I will share some sources with you, and of course they should be available to you after the presentation, so you don't have to run and get a pen right now. But vaccines.gov would be your go-to online. You could actually text your zip code to GetVax, which is 438-8290, or you can call 1-800-232-0233. The vaccines are all free of charge to people in the US, regardless of health insurance or immigration status. And now everyone age 5 and up can get a COVID vaccine. Now, if you're already vaccinated, that is fantastic. Keep up the protection by getting your booster as soon as you're eligible. So for those who have already received the second dose of the Pfizer, BioNTech, or Moderna vaccine, that would be 6 months after that second dose, or 2 months after the single dose of the Johnson & Johnson Janssen vaccine. You should be able to get your booster anywhere COVID vaccines are provided, and everyone age 16 and older should get the booster shot. Now, this is going to be your best protection so far against the Omicron and the other variants is to get this booster. So I just want to offer thanks to all of you who work at community health centers and local organizations. There have been huge strides made toward increasing the number of people getting vaccinated. Because of your hard work, vaccine confidence is growing. However, there's still so much more work for us to do, especially reaching vulnerable members of our own AAPCHO community. So Native Hawaiian and Pacific Islander communities in particular have been disproportionately burdened by the COVID-19 public health crisis. For the state of Hawaii, despite comprising 21% of the population, Native Hawaiians account for 25% of all COVID-19 cases in the state since the pandemic began. Even now, with 72.9% of the state's population fully vaccinated against COVID-19, this statistic obscures the disparities that still exist in the AAPCHO community. This fall, when Hawaii experienced a surge in COVID cases, it took a particularly heavy toll on the Native community, whose vaccination rate is far lower in comparison with the overall state rate. Continued mistrust of the vaccines play a role. We have to acknowledge the historical mistrust that exists among our community and the majority of the minority communities in the US. Interestingly, at the same time, Hawaii has observed a stark drop in the COVID-19 cases among Pacific Islanders since the vaccines became available. Community leaders credit falling COVID-19 cases to grassroots, language appropriate, culturally appropriate outreach efforts to encourage vaccination. Beyond Hawaii, NHPI individuals in many other states have among the highest COVID case and death rates compared with other ethnic groups. However, I believe in being optimistic. So as we close 2021, vaccination rates are promising, not only in our AAPI communities on the mainland, but with 74.8% of the population on Guam being vaccinated and 67.2% on the Northern Mariana Islands. So here we are in the holidays. During the holidays, when you're with family and friends, take the opportunity to share more information with them about the benefits of getting vaccinated and getting boosters. Encourage them to talk to the healthcare provider, such as a doctor, nurse, pharmacist. A healthcare provider is a great trusted person to answer any questions you may have about the COVID-19 vaccines. And of course, help facilitate the people that you care about find a vaccine or a booster at vaccines.gov. I'm very happy and thrilled that Dr. Wang is with us today, who will have the opportunity to share her clinical knowledge and wisdom. Thank you, John, back to you.
Thank you, Dr. Rosario. That was wonderful. I appreciate the information. Well, the news isn't wonderful, but the information that you shared and the next steps that we can all take, it's great information to have. I want to echo your appreciation of all the organizations, healthcare workers, and community members that are working hard to educate and encourage the uptake of vaccinations, especially working hard to do so in language and through respectful, culturally rooted efforts. Please share any questions that you have for Dr. Rosario in the Q&A box. Again, it's on the bottom of your Zoom window. You will see an icon on the bottom of your Zoom window with a Q&A. You can also share any comments that you might have or insights in the chat. Now, I'd like to reintroduce Dr. Cha Wong, who will share important information on booster shots and the Omicron variant. So, welcome, Dr. Cha Wong.
All right, thank you, John, and happy holidays, everyone. Oops, okay, here we go. And thank you, Dr. Rosario. That was inspiring, and really, you know, I work kind of in an ivory tower here, so my hat's off to those grassroots workers who are out there doing the really hard work, reaching the difficult to reach communities in a culturally sensitive manner. That's what we need to defeat this virus. So we're going to switch gears a little bit, and I'm going to talk about some of the clinical data that back up our recommendation about the use of boosters, just so that when your patients ask you about what are the data, that you have some familiarity with what is published out there. And I'm going to cover these three topics here today. One, first talk about the data regarding the boosters, and then talk a little bit about Omicron. I bet 2 weeks ago, most of us did not know that Omicron is the 15th letter of the Greek alphabet. So it's amazing what you can learn as an adult, but now I know that. And then finally, given the data, you know, I think that many of us on this call are going to either test positive or know somebody in our immediate circle who tests positive. So I wanted to touch on that a little bit so we could know what to do ourselves and also be able to advise our patients. John, are you going to, yes, there we go. All right, so I think everybody is familiar with the fact that as of a few weeks ago, the boosters are now recommended for everyone 16 years and up. So, you know, initially they were just recommended for healthcare workers and people in certain professions or people who were older than 65, but now pretty much if you've had the primary series and you are 16 years old or older, you can get a booster. And the recommendations are here. And so for those who are 18 and up, so adults, they can get boosted with either the Pfizer or Moderna. And then if the person is between the ages of 16 and 17, then only the Pfizer is approved for that age group. So that individual would have to get the Pfizer. And then for the Johnson & Johnson, the booster can be given at least 2 months, not 6 months, after completing the first shot, essentially. And that one should be given with the Pfizer or Moderna. So just this week, the FDA announced that the Johnson & Johnson is no longer a preferred vaccine. And in fact, our hospital here, and I believe many hospitals are doing some work to take it off the formulary, and so that it will no longer be available. And so the only indication for a Johnson & Johnson now is if for some reason the person cannot get an mRNA vaccine. And really, there are just no reasons, almost no reasons that somebody couldn't get an mRNA vaccine, just allergy to one of the components or so forth, but that is extremely rare. So essentially, I think that Johnson & Johnson is going to fall off the map. And for people who got the Johnson & Johnson, they should definitely be boosted with an mRNA vaccine. Next slide. So the next few slides I took directly from this presentation, which was given by Dr. Sarah Oliver to the CDC, and the link below is a link to her direct slides. I'm not presenting all of them, but just some of them. But I wanted you to have that link in case you wanted to go back and look at all of the slides. Next slide. So just to orient ourselves, so there are going to be a few graphs that look like this. So I would just spend a little bit of time sort of orienting us to the various pieces of information here. So on the left, we have the major studies that the CDC looked at. And these are all very large and well-designed cohorts. So it's the last name of the person who's the principal investigator, the region, and then sort of some context. And then on the right, VE stands for vaccine efficacy. And then the data are divided as seen in the brackets on the right, at the top into more mild infection, and then at the bottom into severe infection. And so we're going to go through these data a little bit. Now, this presentation was given on November 19th, which was not that long ago, but in COVID time, that was ages ago, because of course that was before Omicron. Our first case of Omicron in this country was identified on December 1st. So these data were collected before Omicron, so it should be seen through that lens. But still, the message remains the same. So next slide. Looking first at the two studies done by Dr. Lind in North Carolina, I wanted to show in the red boxes sort of the data for those who for whom the endpoint was documented or symptomatic infections, so in other words, mild disease, and then at the bottom, more severe disease. So looking at the top red box first, you can see that the vaccine efficacy drops from 95% to 70% if you compare those at 2 months and 7 months. Again, what they were looking at was whether the person developed mild symptomatic infection and went and got tested and tested positive. And then that's shown graphically with the two black dots. And you can see the amount of space between those two reflects the drop in vaccine efficacy. Then looking at the bottom red box, you can see, just eyeballing it, that the black dots are not anywhere near as far apart. And similarly, if you're using the endpoint of hospitalization or death, the drop isn't from 95% to 70% as we saw for symptomatic infection, but was from 96% to 88% for both hospitalization and death. So what does this mean? This means that if you got the primary series of vaccine, in this case, the Pfizer vaccine, even without the booster, and this is again before Omicron, people were well protected against hospitalization and death, but not well protected against having any infection. And so what does this mean? Well, we would like to prevent any infection, because having infection means, of course, that you could transmit it to somebody who is unable to mount a response to a vaccine. And also whenever the virus replicates, it has the ability to mutate, which is what we've seen here with the Omicron. So the message here, though, bottom line is that yes, vaccine efficacy definitely wanes over time. That point is key. And here it's really between 2 and 7 months, so not even a very long period of time, but that there continues to be some protection for these more serious outcomes. Next slide. So the second, these two red boxes here on the second look at the data are from a different study, but showed pretty much the same thing. So I won't go through it in detail. Really just want you to eyeball the distance between the black dots. Looking at the study up top, which is again just a very mild infection, you can see that between the top line, 37 to 66 days, and then 127 plus days, there's quite a bit of distance between those two. And then the lower one, we're looking at, again, the more severe outcomes, not as much distance. So pretty much the same thing, that the primary vaccine series protected well against some of the more severe outcomes, but you did lose efficacy for developing any infection. Next slide. So then we have some data that were presented by Pfizer to the FDA and to the CDC. And I wanted to go through that a little bit. So this was a booster trial. It was a randomized controlled trial so that people received either a booster or a placebo. And of course, it was double blind. As seen in the third bullet, this study was stratified by age. And the booster doses were given 10 to 12 months after the second dose. And why so long, would you ask? Well, because most of the people participating were people who were in that very first wave of vaccine way back now, about a year ago. And then, the booster was not available at the 6-month time point. And a follow-up was about 2.5 months past the booster dose. Next slide. So here we see in the red box, the events, whether you were in the vaccine group or in the placebo group. And in this case, the primary outcome was having COVID, laboratory confirmed COVID. And so 6 people who got a booster developed COVID, as opposed to 123 who got the placebo. So this is a 95% efficacy, as you can see in the rightmost column. So again, very, very efficacious in terms of preventing any infection. And then their data do show, if you look towards the bottom where it says secondary outcomes, those again were sort of your more severe outcomes, did show efficacy in preventing those as well, just simply not as high in efficacy for the reasons that we just discussed on the previous slides. Next slide. And then I wanted to spend a little bit of time on serious adverse events because I think this may be something that stops folks from getting the booster. And then, of course, there's this whole group of people that I've been reading about who had no problem getting the booster themselves, but worry a little bit about giving it to some of the younger people, the 16 to 17-year-olds and so forth. So I wanted to just go through that a little bit. So remember that the Pfizer study was a randomized double-blind study so that some people got the booster and some people got placebo. And so if you look at percent SAE, SAE stands for serious adverse events, you can see that the rate was actually lower in the booster arm than it was in the placebo arm. So just thinking about how these studies are done, the person who's evaluating the patient doesn't know whether they were in the vaccine arm or the placebo arm, would simply report an event as serious, and they would do that, and then it would be looked at later and unblinded. And so, in fact, the rates were higher with the placebo arm. Then they did go ahead and unblind, and they identified a total of 3 serious adverse events among the booster recipients, as you can see in letter B there at the bottom. And those 3 were 1 episode, 1 case of tachycardia, 1 case of elevated liver tests and that were moderate, and then 1 case of elevated liver tests that were mild. So those were felt by the investigators to be potentially related to the booster. Only 3 out of more than 5,000 shots given. There was one death among the people who got placebo and none among the booster recipients. This again was not related to actually getting the shot, but just a death that happened during the study period from an unrelated cause. Next slide. And then in terms of things that I think are good talking points for patients, so there were no cases of anaphylaxis or hypersensitivity identified in those who received the booster. But there was described lymph adenopathy that was seen more after the booster than had been seen after the primary series. So at a rate of about 3% compared to 0.4% with the primary series. These were typically mild. So basically this is swollen glands or swollen lymph nodes, and they were usually located in the neck or in the underarm. And the underarm, I would presume, it doesn't say, but I would presume that it would be the side of the vaccine. So recall that sometimes for women, we recommend that they not have a mammogram initially, immediately after getting the booster or a shot, just because we wouldn't want to falsely identify enlarged lymph nodes and then get concerned about breast cancer and create unnecessary anxiety. And then so the nodes are likely on the same side of that the vaccine was given. These occurred 1 to 3 days post-booster and resolved really quickly. And the frequency was higher in younger people and in women. So again, probably related to a more vigorous immune system in those participants. So really low rate, just 3%, but definitely present. And so if your patient has gotten a booster and complains of pain or swelling under the arm on that side or the neck on that side, I think it's good to know about this and just to provide reassurance. Next slide. And then what about myocarditis? So these data are from Israel, and again, very interesting. Israel has done a great job collecting data systematically and presenting it in a really clear way. And that you can see that just by looking at the rightmost part of this table and seeing that the enormous number of people included. So we're talking about like 1.5 million people. So again, very robust data when you have sample sizes that are that huge. And so in women, after dose 3, there were no cases of myocarditis reported whatsoever. And then in males, you can see the rate listed there in the 4th column where it says post-dose 3 rate per 100,000. The rate was very low, but present, about 5% in people ages 6 to 19 and about 4% in people ages 20 to 24. It went down substantially after that. So just as with the primary series, it was more common in younger people. Oh, I have a question from John here to explain myocarditis. So myocarditis is an inflammation of the heart muscle. We can see that with viruses. It can be a viral myocarditis. We see that with certain viruses, and it has been reported after the COVID vaccine, particularly in young men. Symptoms would include some chest pain, some shortness of breath, some malaise, difficulty taking a deep breath, that sort of thing. Generally, in fact, almost exclusively self-limited so that it would go away within 5 to 7 days, but still scary, and definitely a real thing, definitely confirmed by imaging and laboratory tests. So you can see here that after the first and particularly after the second dose, 16% of males ages 6 to 19 were reported to have myocarditis. And you can see that after the 3rd dose or the booster dose, that rate is actually lower. So in fact, the message to our patients is that yes, you could still see myocarditis, particularly in young men under the age of 25, but the rate after the booster dose is actually substantially lower than the rate after the 2nd dose. We don't entirely know why, but that was reported in a very, very large cohort of people, a couple 100,000. So the risk is low. It's lower than it was after the 2nd dose, and it tends to be mild and self-limited. Next slide. Okay, so next, the slide after this one. Oops, there we go, this one, okay. So just to go through a few things on this slide, I really wanted to show that the bar graph on the bottom. First of all, this is a graph that is a sort of a mathematical calculation of those data and translating it into hospitalizations prevented. And so you can see that for younger people, we're not preventing as many hospitalizations because younger people don't get hospitalized quite as much. Again, this is pre-Omicron. And then for older people greater than age 65, per million vaccine doses, more than 2,000 hospitalizations prevented. And when we think about our hospitals and how full they are, bursting at the seams with burnt out healthcare workers, this number is very, very significant. Then on that same graph, the red numbers indicate the cases of myocarditis that would be expected per million doses. This is based, again, on a mathematical calculation based on the actual numbers of myocarditis that were observed. And you can see that it's 0, essentially, for anybody over the age of 50. And for somebody who is between the ages of 18 to 29, that number would be 7. So 7 cases per million doses delivered. So most of us will never see a case of myocarditis because we're just delivering a fraction of that millions of doses that are being given. But to be aware that it is a real side effect and that it happens very, very rarely. And like I said, self-limited. Next slide. So from these data, what do we know then about booster doses? Well, we know for sure, and we've seen, again, in those very, very large and well-conducted cohorts, that a vaccine effectiveness definitely decreases over time. And unfortunately, the time is not as long as we would like. We're not talking years, we're talking months. So over a 6-month time period, we see vaccine efficacy for preventing infection dropping from 95% to 70%. 70% is still good, but that is a real drop. And then the second, so this lower effectiveness is likely due to a couple of things. It's a combination of decreasing protection or decreasing antibody, and then probably also the fact that as these studies were being done, of course, the variants were becoming more infectious. Delta was more infectious than Alpha and Beta, and now we're seeing that Omicron is even more infectious than Delta. And then finally, the clinical trials that I just went over showed that the booster shot definitely helped to prevent COVID-19 with symptoms, if you remember those graphs and then the red boxes that I showed you, but had a smaller effect in terms of preventing hospitalization and death, again, because some of the residual effect of the primary series. Next slide. So I'm going to switch gears and talk about Omicron. I just wanted to stop here. I don't see anything in the Q&A box. So I'm just going to presume there are no questions about the booster doses at this time.
We haven't seen any, so go ahead.
Okay, great. So I think many of you may have read in the paper about that poor family in Wisconsin that has had this long-standing family restaurant that they called Omicron. It's been called Omicron for decades. So unfortunately now, of course, how were they to know that we were going to have this pandemic? And so they've made T-shirts, I guess, that you could buy at Christmas if you've eaten at that diner to say that you hopefully didn't get corona at the Omicron. Oops, oh, sorry. Next slide, John. So this is, what coronavirus does to us. Every time we think that we've kind of gotten the handle on it, and then something new seems to happen. And it's really hard, I think, to sit back and think about 2 years ago, this time, I know I was getting texts from my college-age daughter saying, is this new virus something I need to worry about? Right around Christmas time, she came back for break. And we were hearing about cases being reported in China. And then, in early 2020, January to March, of course, is when it dawned on us that this was a real problem. And then life seemed to shut down in March. So almost 2 years ago now, and we're going into the holiday season with a lot of uncertainty and a lot of people changing their plans and so forth. So as I mentioned, the first case of Omicron identified on US soil was on this December 1st. So that's not that long ago, right? 2 weeks ago, it was estimated that 1% of the circulating virus was Omicron. 1 week ago, then it was 13%. And today's figures are 74%. And here in Washington State, I'm being told it's close to 100% actually of the variants that are being sequenced are Omicron. So that's what happens when you have a virus that is incredibly infectious and just has a survival advantage over the other circulating viruses. So not only are we just seeing this Omicron take over in terms of proportion of viruses, we're also seeing that absolute viral cases are going up substantially. And I'm seeing numbers from New York where cases are up 80% this week compared to last week. So in just 1 week. And that again is the power of the Omicron. Next slide. And so this is a graph that is updated almost daily in the New York Times. I accessed it yesterday, as I show in the citation. But I circled in blue the area I wanted you to see, because as I mentioned back in February 2020, so almost 2 years ago now, we saw this uptick in the number of viral cases and then shut things down in March. And you can see that slope is a real slope. And all the subsequent waves, again, it's a slope. But now if you look in the right box there, that's not really a slope. That's almost a vertical line. So essentially with the thing that is different about Omicron is that the slope is much, much steeper to the point that it's almost a vertical line. And we're not in the throes of it yet. I don't really think, I think it's going to be the next week or so as it takes over to be 100% of the circulating virus that we're going to see that number go way up. And whether it goes up beyond the highest peak of this curve yet, I think is hard to say. So these are just reported cases now, not thankfully not hospitalizations and deaths, but cases altogether. Next slide. And so what is it about Omicron? Well, unfortunately, Omicron has 50 unique mutations, which are perfectly placed to make it more transmissible and to evade the vaccines. And unfortunately, it's becoming clear that also our monoclonal antibodies are not effective against Omicron. So we have this nice stash of monoclonal antibodies here in our hospital that we are realizing is they're probably going to become useless very quickly here. It's estimated that Omicron spreads 2 to 3 times more efficiently than Delta. And I think what is sobering, if we think about this for a moment, is that if you look at the map in the New York Times or other sources where viral rates are the highest, case rates are the highest, it's actually in the Northeast, which if you keep in mind is also the part of the country that has the highest vaccine rates. So that is fodder, I think, for any anti-vaxxer to be able to point that out, but it is undoubtedly true. Now, the Northeast has always led in terms of, these waves of infection. So I'm not relating this to vaccine at all. I'm just saying if you were an anti-vaxxer, you could sort of point that out. I think what it really is related to is just, the weather, in addition, the sort of population density, and the fact that people move easily between states. If you live in Delaware, you're visiting a different state every day practically. So there's sort of a different sort of way that people behave and people move in the Northeast that makes it prone to these types of respiratory viruses. But then, of course, it then spreads to the rest of the country. The point is that even though vaccine coverage is very, very high there, they're suffering under a huge wave. And I think that for us is a little bit of a crystal ball to let us know where we're going to be here on the West Coast in the next 2 or 3 weeks. There is some suggestion that Omicron may cause less severe disease, and that is certainly what we're hanging on to. That's what we're hoping for. I think it's really hard to say. We don't have any real proof of that. There are no laboratory models that I've seen, nothing like that. But what we know is that a lot of people in the Northeast are already vaccinated and then they're getting Omicron, so they have less severe disease. Doesn't mean that if it attacks somebody who's unvaccinated, that it's going to be less severe. I think the proof is in the pudding for that, and we haven't seen it yet. In terms of what to conceptualize when you're thinking about Omicron and maybe trying to talk about it to somebody else. On the left here, we have this picture electron micrograph of the coronavirus, and the red, remember, are the little spikes that project from the surface that allow it to adhere to our respiratory epithelium, and also that are the target for the vaccines. And so then they've sort of blown that up, and it's really the number of mutations way more mutations than Delta had, and mutations that are in the receptor binding domain. So both the target for the vaccines as well as where it binds to the human epithelium, which makes it both more infectious and also better at evading our vaccines. Next slide. So both Pfizer and Moderna this week have released data that are not published, but just, again, press releases, preprint, to say that the booster will protect against Omicron. This, again, is based on really extrapolation, or really sort of extrapolation of the idea that higher antibody levels are going to protect against Omicron. So what both companies released data showing that if you got a booster and they measured antibody levels afterwards, that these increased greatly. So it was from 25 to 40-fold. And then Moderna separately released some data using a double dose of the booster, which is not used clinically, but they just released it out of interest to show that they boosted 80-fold after getting a booster. And so we do know that the antibodies that we have circulating in our bodies do have some activity against Omicron, thank goodness. I mean, it's not that it's completely not effective like the monoclonal antibodies are, the artificial ones. So the idea is that if you have higher levels of that, you are more likely to be able to fight off Omicron. And so really what we're banking on, because we keep hearing about people who've been fully boosted who are getting Omicron, right? We have Elizabeth Warren and Cory Booker and half the Seattle Seahawks and so forth, all been boosted, all got Omicron. They're not getting severely sick. And so I think what we should be telling our patients is that, you don't want to get very sick from Omicron, and the boosters should be able to at least prevent that if they're not able to prevent a very mild infection. Next slide. Okay, and then as I mentioned, I think with Omicron and as well as the sort of increased popularity of these rapid tests, I think if many of us are going to join a group, for a Christmas dinner or go out to see a Christmas play or so forth, you may choose to get tested with a home rapid test or have access to one where you work. And one of us is going to be positive, if not multiple of us. And so I wanted to just talk about that a little bit. This is actually a picture of my daughter's rapid test. She flew home from college on the Sunday before Thanksgiving, and we did a rapid test on her when she got into the house, and lo and behold, it turned positive. My husband was actually on a conference call, so I took a picture of it and sent it to him. And he glanced at it and thought that it was a pregnancy test, and he was not happy. And so it was actually, he was happy, strangely, to hear that it was COVID, because it's better to have COVID than to be pregnant when you're 20, unless it's a desired pregnancy. So that's a little story from my house. Next slide. Okay, so we're all sitting there at breakfast, and we now have a positive COVID test from my daughter. So what do we do? Well, we were all sitting there. Everybody ran and got a mask. My daughter put on a mask as well. And then we isolated her in the basement. We were lucky enough to have a home that has a basement and a comfortable room there. And so the advice is that if you can do so, to isolate yourself and to stay in your room, even for meals, was to have basically room service, somebody bringing you food, and then you put the dirty dishes out and they take it away. Try to use a designated bathroom. Wear a mask if you have to leave your room, and others should wear a mask if they're around that person. It's of course impractical to wear a mask all the time in your own house. Open windows when possible. Use an air filter if you happen to have one. Here on the west coast of North America, many of us own air filters because we've been blessed by wildfires every summer. And so it has a double use now also in terms of COVID. People always ask, can I find out if I have Omicron? Unfortunately, our tests don't do that. Even the hospital, our tests don't do that. Certainly the rapid tests don't do that. So you would only be able to extrapolate based on data in terms of what virus is circulating locally. If you are over the age of 65 or have an abnormal immune system, or of course, if you're unvaccinated, you should call your PCP to find out if you can get the monoclonal antibody. As I said, we're starting to realize that our monoclonal antibodies don't work against Omicron, but in some parts of the country, we still have Delta and Omicron circulating simultaneously. So for example, I'm giving the monoclonal antibody to somebody today. We don't know if they have Omicron or not, but I figure we've got this stash, it won't hurt. Maybe they still have Delta. And there is a new monoclonal antibody that is effective against Omicron. It just hasn't been distributed yet. So we should have that in the next few weeks. And then for people who have COVID, it's advised obviously that you monitor your symptoms because there is treatment for COVID for people who are very sick. So it's not that you have to stay home and tough it out. Always call your doctor if you have a question. If you happen to have an O2 sat at home, an O2 sat monitor, a pulse ox, it's helpful to measure that. And then to call your doctor or present for care if your sat is less than 93% on room air. Next slide. So here's my daughter. So she rapidly got bored because she actually felt fine. And so she started baking, which wasn't helpful for my waistline. But you can see that she's wearing an N95 while baking, and the rest of us weren't in the kitchen at that time. And then here we are on the right, Thanksgiving dinner. So she is way off in the back there, more than 6 feet, actually we're like 12 feet away from our dinner table. And those windows next to her are open. And I don't know if you can see, but in front of her, there's a little white thing on the ground. That's an air filter. So we put an air filter between her and us, opened the windows, and that's how we had Thanksgiving dinner, yelling across the room. Of course, we're lucky enough to have a room that's big enough for that. Those are my other two kids, my twins and my husband. So my husband was boosted, I was boosted. My twins, got vaccinated in April, so they weren't boosted. I'm sorry, they got vaccinated in June, so they haven't been boosted. But none of us got COVID. We tested daily by PCR, and none of us got COVID from her. Next slide. Here's a graphic that I find helpful in terms of understanding the isolation period. Did you know that isolation and quarantine are two different things? And quarantine actually comes, I just learned this again with COVID. Quarantine actually comes from the French quaranta, which I'm not sorry, not French, Spanish quaranta, which means is 40. And it used to be that when ships docked in Spain, they had to stay, no one could disembark for 40 days because of fear of infectious diseases such as typhoid fever and cholera and so forth. And that's where that term quarantine came from. So quarantine is if you don't have the infection, but you're waiting to see if you get it. Isolation is if you do have the infection and you're waiting to become non-infectious. So it's just kind of semantics, but I think I always like to think about where words come from, and it's sort of interesting. So this, in terms of somebody who has infection, is the isolation period. And I invite you to try to be the mother of a 20-year-old who feels fine and now has to be stuck in the house for 10 days after just getting home from college. It's not fun. But it's actually, and then she was arguing with me about every single day, what is it, day 1 or day 0? So day 0 is the day that your symptoms start or that you test positive. That's 0, not 1. And then you go 10 days, and then you don't leave the house on day 10, you leave the house on day 11. Believe me, we had a lot of arguments about this, but these recommendations are from way back when people were unvaccinated. And so I am really thinking that as more and more people test positive for Omicron, that this is going to change because the time, so we were actually testing her starting at day 5 with a rapid antigen test. She tested negative on day 5. And so, I think for vaccinated people, this time period is actually much shorter. And especially since I do anticipate that a lot of healthcare workers are going to start testing positive for Omicron just because it's so infectious. Of course, we don't want our healthcare workers out for 10 days if they're home feeling fine. I think that this particular graph is going to change, but this is the current recommendation. I should also mention that the CDC has said that it's okay for people to leave the house if they're going to exercise on their own. So go for a walk, go for a hike, as long as you're going someplace that's not crowded where you don't anticipate seeing people and you're masked. But that person, the infected person, should not be going into a store or into a restaurant, masked or unmasked. They're supposed to stay in the home, except being allowed outside for exercise. Next slide. Okay, so what about some practical considerations? As I said, I just went through this myself, and I can tell you that the person is just, chomping at the bit to be released from isolation. And so what we did, and actually on the CDC website, it says that this is one thing you could do if everybody in the home is fully vaccinated and nobody is high risk, the infected person could be tested around day 5. And if they're testing negative, you could choose as a family to release that person from isolation within the house. So in other words, they don't have to wear a mask when they leave their room anymore. You don't have to wear a mask around them. And then you can relax restrictions. So my son, who was at the, who you saw in the picture, when he got back to school and he said, what did you do over Thanksgiving break? He wrote an essay that was entitled, "Watching Marvel movies while wearing an N95 mask is not fun." Because we decided that since she was stuck in the house, we were just going to binge the Marvel movies, and there are 35 of them now, I know. And so, but she and us all wore N95s while doing so. And so that was his takeaway from Thanksgiving. Okay, so and then, like I said, because everyone's going to start testing positive for Omicron, what do you do if you're exposed to someone? So if you're fully vaccinated, remember, you do not need to quarantine anymore. Yeah, back in the day, before vaccines, we needed to. We don't need to anymore. The idea is test to go out and about. So you monitor for symptoms and then get tested if you have any. And it's recommended that people test at days 5 to 7 after exposure, even if no symptoms. But you can go to work, you can go to school, etc. Next slide. Any questions at all? I see there are a couple. I just need to do a quick time check. Sorry.
There are a few questions for you, Dr. Wong.
Okay, yeah.
You may have maybe 2 minutes for
Yes,
a lightning
yes,
round in a
yes,
sense.
of
I
course,
know some of these are longer, and we could also.
And I can also get back to people after.
Yeah.
Yep.
That would be great if we could pull the questions and also send it out when we send out the recording and stuff. So there's a question about bears. So there's are you seeing the Q&A?
Yeah. So how do you respond to this agency showing that has a shot in the virus? I am not familiar with those data. I don't think they're correct. I'm quite sure that they're not correct. I'll have to look at that more closely though and see where that came from.
Okay, thank you.
And then how often do we suggest you get COVID tested even if you're vaccinated? Really, you should test only for symptoms unless you're testing because you're going to go visit somebody who's at risk. Or you're testing because you were exposed, as I mentioned, even without symptoms, you should get tested. But there's no like you should get tested once a week sort of answer. It's really if you have symptoms, if you're going to go somewhere, you want to be as sure as you can that you're negative, or if you've been exposed. And then I think the isolation question I answered with that graphic, but it's going to change. I'm quite sure it's going to change. Why is focus only one-sided with the jab? What is coming? Oh yeah, well that is all true. And I decided I was going to walk to work this week. It's 5 miles, but I decided that since Omicron is around, the best thing we can do for ourselves is to make sure that we're in this as good cardiovascular health as we can be, and control things that we can control, like blood sugars and hypertension, and getting enough rest, etc.
Can I jump in real quick about that to answer that question as well, to contribute?
Yeah.
There is a whole, we're here today specifically talking about COVID. So that's why we have that kind of singular focus. However, this is a whole space in research and in science and in medicine, which is minority health, health disparities, health inequity versus equity. So there's definitely a far larger conversation and, scientific data that's being about overall immune system, eating healthy, sleep patterns, stress, beyond that, social determinants of health, all very much focused on all the different racial and ethnic minority communities and the health disparities that exist among them.
Right, yeah, so true. And then the last question about whether my daughter was vaccinated, she had been fully vaccinated with the Moderna. She's very healthy. She was actually due for her booster, but she had just taken her finals. So we didn't want to give her the booster, during her finals. She was supposed to come home and get the booster, but she came home and she had COVID instead. She just got the booster though, because she's getting ready to go to Spain. She actually recovered from COVID and went to London where they're having this big Omicron thing going on. And she went with 10 of her friends. 3 of that group had COVID. They all got COVID at the same party. And the other 7 hadn't. They're all fully vaccinated. Of the 10 who went, the 7 who had not gotten COVID at school got COVID in London, and they all have it now. So, it was basically 100% of that friend group got COVID, either at the party they went to right before they left school or in London, because that's where Omicron is circulating. So that's why I spent time talking about what to do if you test positive, because I think it's very likely that a lot of us are going to test positive. The good news is they all had very, very mild very, very mild disease, and they're all fine.
Okay, I'd like to contribute to that as well. My daughter's 11, she's in 5th grade. She's vaccinated. However, in her school, there's this week, there's been like this small outbreak of infections among 2nd graders and among staff. So far, the vast majority of folks in our community, I hail from Maryland, and most people are vaccinated. And as soon as it became available to the pediatric, community 5 and above, people have been vaccinating their children. So we're definitely seeing, drastically less severe outcomes and symptoms and experiences of COVID among, these vaccinated kids.
I think the big question is whether they're going to be going back to school after the break. I have 13-year-olds as well. I'm fully anticipating that they don't go, that we're going to be remote for a week or so, but we'll
Yeah, I agree. I think we're seeing, I can confirm that after Thanksgiving, there was a little spike in infection rate because of the reunions of everybody getting together. I think it would be safe to say we could expect the same after, this segment of the holiday winter break. So I do believe that systematically everybody's kind of prepared for this possibility that it might be wiser based on these numbers for everybody to kind of go remote for a moment and then come back. The good thing is that since we've already kind of overall adjusted and moved in that direction of infrastructure capacity to be able to like fluctuate between remote and in person, we're definitely seeing kind of these smoother transitions and things kind of, kind of being jolted back to normal, like this attempt to be back to normal. Yeah. So I don't think anything's gonna be as drastic as last year would be my assumption.
I've got to run, but I appreciate everybody's attention and contributions, and I will get to the other questions when I get back. Okay.
Great. Thank you. Thank you, Dr. Wong.
Thank you so much. Everybody have a happy holiday.
All right, you too. Yeah, so I want to thank Dr. Wong again. I know she just had to leave, but the information on Omicron and other variants are evolving every day, and I appreciate how she helped us get a great baseline of understanding how best to protect ourselves. We are at time. There are 2 questions here that I do want to honor. Dr. Rosario, if you feel comfortable answering these, or we could also add this to the list that Dr. Wong can answer as well.
In regards to travel, at least, I think that we have enough information. This is our first rodeo was last year. So I think that people are overall being a little bit wiser, more conscientious. Obviously, federally, you are obligated to wear the mask on the planes, etc. I chose to drive to get to where I needed to be for the holidays. But again, I don't think it's any more dangerous, for lack of a better word, than what it has been in the past, given that we are collectively more, the vaccination numbers only continue to rise, and that is kind of where the safe space is created. So again, yes, Omicron might be spreading, but for those of us and the majority at this point that are vaccinated, it's not going to be severe. The symptoms are going to be so serious. It's not going to be anything worse than what we've contended with in the past. The important part here, and what I do want to drill home, is this opportunity now in the holidays that we're with family and friends to spread accurate information, to spread, all the success stories, all the ways that we can be doing things now, because the majority of the groups are, vaccinated. The families might have a few individuals, 1 or 2 or 3 or 4, but, collectively the vaccination rates are increasing, and that is what it's supporting the opportunity to do these things. So we need to leverage it. And now that we are with family and friends, now that there's more of us, the kids are, able to partake as well with our older generation. Again, it's a great opportunity to spread the information, the encouragement to get the information, the data, so that hopefully next year we're not kind of contending with a new variant, because that's really going to be the only one of these variants, which is the collective vaccination.
Yes, thank you, Dr. Rosario, for those thoughts and the facts around that, and that we are at a different place. So I also want to recognize that it's at 2:04, so we're a few minutes over. What I'll do, we're collecting all the questions, and we'll make sure that we have answers to send out as well. Dr. Rosario, is there anything a final thing you want to share before we transition out and thank everyone for being here?
No, everybody stay safe, stay healthy, have a wonderful holiday season, and please share the information.
Thank you. Thank you for being here, Dr. Rosario. It was a wonderful to hear from you, and I'm glad that you were able to do this, and as well to you. Have a safe holiday with your family, and take care.
Thank you so much. Best to all.
All right, thank you. So everyone, please, there's evaluation questions, so please answer those. And you can also answer the survey as we log out. Again, we will send the recording and the slides to you. Go to the next slide really briefly. Oh, okay, I guess we don't need to. We'll send you links to more resources. We collect them at AAPCHO, but also we'll share some AIM language resources as well. And again, just thank you all for participating in today's webinar and the importance of booster shots for Asian American, Native Hawaiian, Pacific Islander communities. At AAPCHO, we believe that health centers and community-based organizations have the ability to build vaccine confidence and advance vaccine equity for under-resourced communities. And we would love to thank HHS for the partnership, and we are honored to be part of the We Can Do This campaign. So thank you all for being here. Have a safe holidays, and please let us know if you have any other additional questions. Feel free to contact us on our webpage, and there's many ways to contact us. So thank you again.